My name is Yared Alemu. I'm the founder and CEO of TQIntelligence. I'm a psychologist by training, and I've been in this area for for about 20 years. And so one of the reasons why we focus on children and adolescents is mental health issues are primarily a disorder of young people before it becomes a disorder of older people. And one of the reasons that this issue is important is because 80% of the mental health problems are primarily accounted by a history of trauma. So pediatric trauma precipitates depression, anxiety, and other disorders. And trauma is not just an emotional problem; it's also a physiological problem. There are a significant part of different organs that are activated to create this complicated issue. So we're on a mission to support our providers and payers in doing three primary things to address this problem. One is a rapid digital screenings that to do it objectively, and the other one is tracking outcomes consistently, and then to be able to monitor patients remotely. Because problems don't wait until someone shows up to the office. It tend to be continuous, and especially for high-risk patients. So, in particular, the thing that differentiates from other kind of these measurement-based systems is our focus on objectively quantifying and predicting the severity of the emotional and behavioral disorder. So we use voice, and we're developing these biomarkers that are indicative of the severity of the emotional distress that underlies almost all other diagnoses. So these algorithms allows us with about a 60-second voice sample to be able to track, to be able to monitor, being able to screen quickly and give that feedback in real time to providers. And so there's a lot of great voice companies. So our differentiator is one, we're exclusively focusing on children and adolescents. It's much more easier to prevent proactively, to divert severe emotional behavioral disorders that tend to disable adults at the later age. And we're also focusing on our approach to developing these algorithms are much more clinical and surgical, that the voice samples that we use to develop our algorithm is a clinical voice samples that we collect from children and adolescents who are currently in treatment from low-income communities. And part of that is trauma is disproportionately experienced by people from low-income communities. And these traumas are traumas experienced in the home, traumas experienced in the community, these traumas experienced in school, and currently COVID-19 exacerbates these pre-existing disparities in treatment outcomes. And this is one of those things that are kind of mind-boggling, right? The amount of money that goes into trying to treat this. So for kids from low-income communities that qualify for Medicaid, currently, there's about 5 million of them that are receiving mental health services. It's $250 billion a year, right? It's $250 billion a year for, we don't know what the return on the investment is. So there's limited evidence that this is actually making a difference, despite the kind of money that pouring into that area. So our system that not only quantifies and predicts and monitors, it also creates a level of transparency that both the payer and the provider can see whether these intervention by these different providers is making a difference or not. So again, if you invest $250 billion a year, you should expect something in return, not anecdotal or testimonial, but data that clearly shows that kids that are in this area are the quality of life is improving, the rate of suicide is decreasing, the rate of engagement with the criminal justice system is decreasing. The number of hospitalizations in emergency room visits are so we know what the markers are. We just don't have any evidence to support that this investment, there is a return in this investment, right? The other thing is, we have a great team that's dedicated, that's diverse, and highly trained, and they're focusing on both in terms of the technology and the clinical side. So So we're very confident about being able to deliver these solutions to our customers. And so a couple of things in terms of traction, and one is we are recently awarded $1 million from the National Science Foundation for a phase 2 SBI grant, and that will be matched by an additional $500,000 from that we raise sometime in the short term. So we're very excited about this grant from NSF. So we appreciate any potential collaborations. So we're not planning to raise until 2022, early 2022. But if you're a pharma, we can help you develop. There's no medication right now that directly targets pediatric trauma, right? And so the voice biomarkers that we develop could be helpful in developing these specific interventions for this population that tend to suffer quite a bit. If you're a Medicare managed care organization, we have the tools to allow you to be able to collaborate with providers based on data and administer value-based services. And if you're a telementalist provider, we can white label our algorithm to help you track outcomes for telementalist services. And so we look forward to responding to any questions that you have, and hopefully we can be able to have some conversation about potential collaboration.
Thank you, Yared. Awesome. I'm going to take some questions here from the Q&A. And I think it's always great to dig into the why of, why are you doing what you're doing? Why did you choose voice, and why are you focusing on young people?
Voice partly is because it's the most available and simplest form to develop a biomarker for a disease. So unlike face recognition technology, or for example, blood work, for example, to check the level of cortisone that indicates the level of stress, this gives us, the technology in its early stages, right? So it's an emerging science. There's a lot of opportunities. There's been a lot of progress that's made. So even the funding in this area has been kind of heating up recently, partly because of the success of a couple of companies that are able to develop algorithms for depression and anxiety.
The technology is really interesting, and the potential for impact is obviously huge, but it's going to be no easy feat to reach Medicaid youth at scale. So talk to us a little bit about your strategy for doing that. Yeah.
So we have currently run about 3 pilot sites with large community behavioral organizations with a total of about 13,000 patients. And so they provide treatment for the most severe population when it comes to mental health. And these Medicare managed care organizations manage about 95% of the Medicare population, right? So they act and behave like any other health plan. They just happen to operate slightly differently, but partly because unlike in the private plans, they have capitation. So they're asked to deliver services in the money that's already negotiated. And so they have a lot of incentive to make sure that they can be able to keep that capitation. And one way to do that is to improve outcomes and being able to work with their providers in a more collaborative way clinically.